Welcome to our video on microvascular kidney complications in diabetes. Diabetic microangiopathy is a direct effect of chronic hyperglycemia, which means that it's strongly correlated with long-term poor glycemic control. So let's briefly review the pathogenesis from step one. Okay, so hyperglycemia is particularly toxic to the endothelium. And here you can see the endothelial lining of a blood vessel, and excess glucose leads to glycation of multiple tissue proteins and lipids. And then there's these advanced glycation end products that are actually toxic to the endothelium, and those cause the generation of reactive oxygen species. And that eventually leads to vessel inflammation and damage. And the most commonly affected vessels are the retinal vessels, which causes retinopathy, and glomerular capillaries, causing nephropathy. And also there's vasonervorum, which are the small vessels supplying peripheral nerves, and that's what causes neuropathy. Now let's come back to this slide. So there's endothelial dysfunction, and that's responsible for diabetic retinopathy, nephropathy, and neuropathy. And hyperglycemia has that direct toxic effect on neurons, which contributes to that diabetic neuropathy. And actually, the development of diabetic neuropathy combined with peripheral artery disease may give rise to a number of foot complications such as arthropathy and foot ulcers, and we call that the diabetic foot, and that's actually discussed in a different lecture, along with neuropathy. Now, there's strong evidence that strict glycemic control can reduce the risk of development of these issues as well as progression of these, and that makes sense. If hyperglycemia cause these problems, then it makes sense that if you can control that hyperglycemia and that blood sugar level, then you can prevent it, or once it's started, you can prevent it from getting worse or slow it down. Now, since the development of these complications takes about 5 to 10 years, screening for these issues should start within about 5 years of the diagnosis of patients with type 1 diabetes. However, when it comes to type 2 diabetes, this is often present for more than 5 years, even before the diagnosis. And the patient may have already developed a number of these complications by the time you actually can diagnose it. So the screening for retinopathy and nephropathy and neuropathy basically occurs as soon as you make the diagnosis. Okay, now let's do a quick question. What chronic complications of diabetes mellitus are prevented by strict glycemic control? So to answer this question, you really just need to think of complications of diabetes into two broad categories. There's microvascular and there's macrovascular complications. So strict glycemic control can help prevent microvascular complications, which are the ones that we're discussing now, like retinopathy and nephropathy. Whereas the effect on macrovascular complications isn't totally certain. And we actually discussed that in the lecture where we talk about stroke and heart attack and things like that, because those are all macrovascular complications. So what's the take-home point? Glycemic control can actually help prevent retinopathy and nephropathy. In other words, the microvascular complications of diabetes. Okay, now let's dive into diabetic nephropathy. Now, an important fact to know, just to recognize how significant diabetic nephropathy is, diabetes is the most common cause of end-stage renal disease in the United States. And to understand why, let's look at this diagram. You may recall from step one that glucose is absorbed from the proximal convoluted tubules of the kidney, along with sodium via that sodium-dependent glucose cotransporter. And in diabetes, the increased filtered load of glucose and the increased glucose delivery to the PCT results in increased activity of those sodium glucose cotransporters. So what happens is there's this increased transport in both glucose and sodium out of the lumen, and that reduces sodium delivery to the DCT. And that results in activation of the juxtaglomerular apparatus. So less sodium here means that there's increased stimulation of the apparatus here, and therefore increased renin release. So the renin-angiotensin-aldosterone system is upregulated. And as part of that, angiotensin II levels are high, and those cause constriction of the efferent arterioles. So what does that do? Well, it reduces the blood flow out of the glomerulus. So there's this backup of blood within the glomerulus, increasing intraglomerular pressures, and of course, increased GFR, because there's more blood being filtered. But that increased pressure actually causes damage, and that continued damage results in progressive thickening of this basement membrane you can see here around the glomerulus. And that damage over time causes many issues, including protein leakage and other problems of end-stage renal disease. So the take-home point is that diabetes causes increased intraglomerular pressure, ultimately damaging the nephron. Okay, so let's come back to this. Hyperglycemia stimulates the renin-angiotensin-aldosterone system, which causes vasoconstriction of the efferent arterioles, which leads to increased GFR. And that perpetually high intraglomerular pressure leads to damage, particularly of the glomerular basement membrane, And eventually that leads to proteinuria, progressive glomerulosclerosis, and Kimmel-Still-Wilson nodules. Now these Kimmel-Still-Wilson nodules are nodular hyaline deposits within the glomerulus, and they're pathognomonic for diabetic nephropathy. So if you see these, then you know that the cause of the renal damage is diabetes. So let's show you what these look like. So here's an image showing the glomerular tuft in diabetic nephropathy. And you can see these pinkish homogeneous nodular areas. Those are the Kimmel-Still-Wilson nodules. And again, if you see them, that's pathognomonic for diabetic nephropathy. Now let's discuss the clinical manifestations of diabetic nephropathy. The early stages are pretty much asymptomatic, as you'd expect. There's so many nephrons, and it takes a lot of them to get damaged before the patient actually starts getting symptoms. In fact, one of the first signs of disease is asymptomatic microalbuminuria. So you can start seeing albumin or protein leaking into the urine, even though the patient doesn't have any problems yet. So we'll discuss exactly what's meant by microalbuminuria in a moment. But for now, just understand that we're talking about a very small amount of protein being leaked into the urine, and it's abnormal. Okay, so it's at this asymptomatic stage where glycemic control and secondary prevention with drugs becomes crucial, because those measures can actually slow down the progression and prevent even more advanced stages of diabetic nephropathy. Now, if not controlled, then that continued glomerulosclerosis and that basement membrane dysfunction of the glomerulus can lead to hypertension and proteinuria, or even what's called a nephrotic syndrome. So that hypertension can exacerbate the diabetic nephropathy. Now, this hypertension is very important. And again, it's logical that it would occur because we're stimulating the renin-angiotensin-aldosterone system, and that perpetual hypertension can further increase that intraglomerular pressure. Okay, so the idea is to start controlling blood sugar levels really well during this asymptomatic microalbuminuria stage. But once frank proteinuria develops, then the role of glycemic control actually diminishes, and the progression to chronic kidney disease is pretty much steady. So you've almost lost your chance, is a way to think of it. So at that point, there's progressive decline in the GFR, and eventually there's signs of chronic kidney disease. So again, take home point here, start controlling blood sugar levels really well during this asymptomatic microalbuminuria stage. So as already mentioned, it's crucial to detect this diabetic nephropathy at the stage of microalbuminuria, but the question is, how do you screen for it? Well, the most sensitive test is the urine albumin to creatinine ratio, or the UACR for short. Now, thankfully, this does not require a 24-hour collection of the urine. In fact, all you need is a spot urine sample. And normally, the ratio is less than 30 milligrams of albumin per gram of creatinine. So less than 30. That's normal. But if the ratio is between 30 to 300 milligrams per gram, then this is termed as moderately increased microalbuminuria, and that actually indicates that there's development of the diabetic nephropathy. Then, if the level is greater than 300 milligrams of albumin to grams of creatinine, then that's termed macroalbuminuria or macroproteinuria, and that indicates advanced diabetic nephropathy. And that's unfortunate because you want to prevent this. Now, a very important point is that a routine dipstick actually does not detect microalbuminuria. So you don't use the dipstick as the screening test. So you collect the urine using a small spot urine sample, but it's not the dipstick. So I just want to make that clarification. But let's think about why the routine dipstick is not useful in screening. Well, it's because it can only detect when the albumin level is greater than 300. So when it's far too late to try to prevent the progression of it, because it's already happened. So an ideal screening test would be one that catches it early, not this late. So again, the routine dipstick is not that helpful. Okay, now let's talk about management. So intensive blood pressure control and glycemic control, which includes lifestyle modifications, can reduce the risk of developing diabetic nephropathy. Also, all patients are annually screened for moderately increased microalbuminuria. And recall that the definition of moderately increased microalbuminuria is between 30 and 300. And of course, you do this using the urine albumin to creatinine ratio test, using a simple spot test. So let's say your patient comes up positive. They're above 30, below 300. So you're thinking, okay, we're a little bit worried about the development of diabetic nephropathy at this point. And if they persist at this level, the MIA or moderately increased microalbuminuria, for longer than 3 months, then you can diagnose it. You say, okay, you've got diabetic nephropathy. And once it does develop and you've diagnosed it, then you're going to give ACE inhibitors or ARBs. And it's important to know that the renal protective effect of these drugs is actually independent of their antihypertensive effect. So that means that all diabetic patients with hypertension are given ACE inhibitors or angiotensin receptor blockers, whether or not they have developed diabetic nephropathy. And all patients with diabetic nephropathy are given these drugs whether or not they are hypertensive. But if they happen to have both this nephropathy and hypertension, then ACEs and ARBs can help both of them. Lastly, annual BUN and creatinine levels are actually done in all patients, even in the absence of microalbuminuria. And you do this to estimate the GFR and screen for chronic kidney disease, because it's possible for patients to progress directly to renal failure without even having that proteinuria in between. So you need to do this BUN and creatinine measurement to be able to catch those cases. Let's just do one quick question before we wrap this up. What's the screening test of choice to screen for diabetic nephropathy? It's a urinary albumin to creatinine ratio. And remember that this detects microalbuminuria, which is an early sign before the full-blown development of diabetic nephropathy, and it's not picked up by the routine dipstick. So again, the albumin to creatinine ratio. And that concludes this section.